Hi everybody. I also want to thank the organizers so much for inviting me to participate in this fantastic day of panels. I'm really glad to be here. So, everybody can hear me okay, right? Yeah? Okay. What I'm going to talk about today is a lot of people have presented work that they have been doing for a long time, or just completed. I'm kind of doing the opposite. So this is a super new project for me. This is actually the first time I'm presenting this particular tidbit of research, and it really only is a tidbit at this point. So I'll just foreground this by saying I'm trained as a medical anthropologist, so I'm coming at at my topic from that angle, and most of my work to date it's always been on health inequalities, but most of it's been in global health. And I'm starting a very new project on health and aging in the US prison system. There are actually some parallels between those two arenas of research that might not be obvious, but I'm really interested in medical care and research in what get thought of as exceptional settings, and that's true, I would say, in global health, and it's true in the prison setting too, that perception anyway. So what I'm going to do is just start with a vignette that I've encountered in the kind of preliminary field work that I've been doing, and then use that vignette to basically raise some questions that I hope to explore as this project hopefully unfolds. So the setting for the vignette is basically a conference that I attended in October 2016 that was put on by the Washington Department of Corrections. Some of my fieldwork has involved kind of hanging out with administrators at DOC headquarters, attending some of their meetings, and through this I was able to go to this conference. It's an annual conference that is basically targeted at DOC healthcare workers and administrators. And this particular moment that I'm going to describe happened during a presentation on ethical dilemmas in correctional health care. And the presentation was by a clinician, but he's a clinician in a high-level administrative role, so not someone who was actually working at the facility level. He was a headquarters guy. But many of the people in the audience were clinicians who were actually practicing at the facility level. Direct patient care. So this doctor was giving this talk on ethical dilemmas, and he described a series of different ethical dilemmas that can arise in prison healthcare, as well as different legal and ethical guidelines for care in prison. None of his scenarios had anything to do with end of life, though. So he goes through his scenarios, and then people in the audience start raising hands and saying, well, what about this kind of situation? What about that kind of situation? And one of the doctors from one of the facilities who works in the inpatient unit, so a lot of facilities have regular like infirmaries, like a clinic, an outpatient clinic. But he worked in one of the facilities that actually has a sort of a hospital inside, an inpatient unit. And he described this, he described a particular scenario, although he said it wasn't the only time that he'd encountered this dynamic. And the scenario that he described was having a patient who was terminally ill, who was dying, and inside the inpatient unit, but refused to sign, or did not want to sign, a DNR, a do not resuscitate order, while he was incarcerated. He insisted he wanted all measures taken to preserve or prolong his life, even though he was in the process of dying. So he didn't sign the DNR, his condition deteriorated, and he was then, when he got more ill, or you could argue closer to death, he was transferred out of the prison to a hospital in, I don't know, in DOC they call everything outside the prison the community, which for some reason is very weird to me, but I guess I'll use that term. Yeah, so a hospital in the community, i.e. outside prison. And it could have been an ICU like at Harborview, I don't know, so he was transferred there. And so when you switch facility, or when you switch institutions, you have to review whether your DNR status again. And once he arrived at the outside hospital, he signed a DNR saying, like, you do not need to resuscitate me, like, do not take all active measures, please let me die. his goal was essentially I don't want to die in prison, understandably. So what happened, though, was actually that he stabilized. He stabilized to the point where he no longer required the ICU level of care. And so according to the rules that govern all this kind of stuff, he was transferred back into the prison facility, into the inpatient facility, where he again refused to sign the DNR. And again, his health got worse, and he, to the point where he needed more advanced care than could be provided within the prison, and he was transferred back out into the ICU again. And again, he stabilized. And so at that point, when the hospital was saying, okay, we're going to transfer him back into you guys, the doctor who was telling this story was like, no, like, I'm not going to take him back unless if he signs the DNR, we'll take him back, but this is ridiculous. And I would say the doctor said to me afterwards, because I chatted with him about this, he said no one should die in prison. So he wasn't supportive of, he understood what the patient was doing and was not against it. He just was kind of like, just let him stay where he is. Let's not keep, doing this over and over again. And the family also, and he was being visited by his family outside in the hospital, and the family actually at one point said to this doctor, if he dies in prison, it's on you. We hold you responsible. What happened was that the patient did remain in the outside hospital in the community, and he eventually did die there where he could be visited and be with his family. Be visited easily and be with his family. So that's the vignette. And I know that this panel is supposed to be about the big picture, and I've started on a super micro level with one story because I'm an anthropologist, and that's how we roll. But I will give some numbers that to give some context to this, and then I'll talk about what it's making me think about. So in terms of mortality in the U.S. state prison system, so this doesn't include federal, but most prisoners in the U.S. are in the state system. So given that we are here to talk about race and inequality, I will just say the obvious, but I'll say it anyway because it needs to keep being said, that this is in the context of mass incarceration that is racialized in this country. So race is always a part of this picture, both in terms of who is disproportionately being incarcerated, and also, I would say, what's happening within the prison in terms of care. Certainly, I imagine is that the care itself is contingent upon race and racism as well, and that's not something I've studied, but I'm sure it's there. So this is definitely a part of this picture. I will say that, so we have this context of mass incarceration, and the number of prisoners who are over the age of 55 is increasing. So it's gone up more than 5-fold since 1990. And interestingly, at this particular moment, we are succeeding a little bit in chipping away at mass incarceration, and that numbers are starting to decline slowly and in a small way, but they are declining. But deaths in prison are actually rising, even though the number of people incarcerated are not. And in state prisons, these deaths are mainly due to illness. So these are not violent deaths, they're not suicides, as they often are in the jail system. These are things like cancer, heart disease, liver disease. So people are often getting aging, or they come in with chronic conditions and they're dying of them in prison. And so these are just Bureau of Justice Statistics numbers. In state prisons in 2013, there were 3,487 deaths, and that was actually the highest number that they had reported since they started collecting data in 2001. So that seems very significant. And the doctor who told this story said, actually, this is something that I've seen. This is not just this one patient who something like this has happened to. I've seen this happen more than once. So we can assume that more and more people, not assume, we know from these numbers that more and more people are experiencing end of life in prison, and there are a lot of reasons for that. Sentencing laws, some successes at getting the death penalty eliminated, coming with an allowing of life without parole sentences instead. So there are people who are just remaining in prison for very, very long periods of time and are aging there, and some of them are dying while they're still incarcerated. So the last bits of this talk, or the last second half-ish of this talk, I think I have about half my time. Maybe not. 5 minutes? I have like 5 minutes? I do? Okay. I just want to think about the three things I mentioned in my title, so care, control, and freedom, and how we might think about those, or how I might think about those, again, moving forward with a very, very early project. So care, and I should say none of these images are mine, because one of the reasons why this is a preliminary project is because it's hard to do research, especially ethnographic research, on prison healthcare. But this is an image from a Washington State facility in Shelton that I got from the news. So a reporter took this. Thinking about care. So there's a few things, and a lot of this is not, this is not me. This is stuff that people have been studying for a while. So the context of care in a prison context, bioethicists call it a context that's plagued by dual loyalty. So loyalty split between that loyalty to one's profession as a care provider and loyalty to one's employer, the Department of Corrections. And this isn't the only place where dual loyalty can happen, or problems of dual loyalty can happen. People talk about it in the military, also in military care. And there's probably other examples too. So that we can see that happening here. I would say that we also see conflicts between notions of what constitutes good care. So in the Department of Corrections, according to their policies and their what's called the Offender Health Plan, they provide care. They provide what is care that is medically necessary. So that's the legal language. It's, I think, borrowed from Medicare, Medicaid, but it's a prison healthcare is highly litigious. So the wording is definitely specific to that. So they see themselves as legally obligated to provide care that is medically necessary. So that is good care within the prison setting, is medically necessary care. But if you look at bioethics, if you look at the anthropology of care, good care and the sort of philosophical approach to care, good care is care that's empathic. It's care that's relational. Care is seen as a relational relationship, a relational thing versus a transaction, and that it's humanizing. It's seen as a fundamentally kind of humanizing activity, both for the receiver and the giver of care. So these are these two definitions of care, they don't necessarily exclude one another, but they certainly are pretty different in what they emphasize. Sort of medical necessity versus empathy, relationality, humanization. So that's one thing to think about moving forward. And I think we can see that in the conflict over care in this case, in that the DNR, it was appropriate, we could say medically appropriate, for this patient to actually have a DNR, given that he was terminally ill and he was actively dying. And if he hadn't been imprisoned, that probably would have been deemed good care, both kind of biologically and also empathically, in that resuscitation efforts are violent, or can be violent, and really not have good outcomes, especially if you're already terminally ill. But in this case, the best care was actually to not let him die in prison, and to have him be able to die outside, where he could be more easily surrounded by his family. So I think those are the kinds of things that I've been thinking about in relation to care. Now, care in the prison is always in tension with the prison goal of control. Again, this image, I did not take this image, and this image actually is not from a Washington facility. This is a facility, an image from a Raleigh, North Carolina prison, from like the architect that designed this, the architect firm. But this is a sample of what an inpatient room might look like. I've never been in the inpatient wards in Washington State. I have only had them described to me. But I think it's important to think about, well, what is the space that this patient might have been in while he was still inside the prison inpatient hospital? And those spaces are essentially locked individual rooms, because the inpatient hospital has to abide by the highest level of security that any patient in the system, because they're getting patients from all over the system, any patient in the system might have to, might be categorized according to. So even if the facility itself that the hospital is in is a medium security facility, the inpatient ward would be maximum security because they potentially could have maximum security patients coming from other places or other parts of the prison. So it's maximum security, which means people are basically alone in a locked hospital room. Giving healthcare in prison is this constant tension between medicine and kind of the efforts of medicine to humanize, and issues of control and custody, and the custody side of the prison seeing everything as a security risk. So the people who occupy this kind of inpatient unit are people who are at end of life, but they're also people who are not dying or at the end of life, but have certain kinds of durable medical equipment, colostomy bags, things like that, that cannot pick lines, that are seen as security threats if they're taken outside of this locked ward. So it's not a great environment to be in. You can get visitors, but the visitation is quite limited, and because the security grade is maximum, even people who are at end of life who have more access to visitors, there's only room to have one patient having visitors at a time. Again, compared to being outside in a hospital where your family could come and go, it's much more restricted. So control, and because I'm running out of time, I'm going to move on and just talk a little bit about the last thing that this vignette is having me think about, and that maybe we can all think about, is freedom. So what are the options for freedom in this kind of scenario, not just for this individual patient, but in the context of the system at large? So I have a few ideas at different scales. So for this individual patient in the vignette, freedom was kind of strategically using the rules that govern DNR orders in order to assert his autonomy as a patient to avoid dying in prison. And so these kind of extreme cases, life or death scenarios, are the few instances in which medicine can actually trump custody. Usually custody trumps medicine, but when it's a life or death, like emergency care, end of life, then sometimes medicine can trump. So he was very strategic in doing that, and he succeeded in not dying in prison. But that's just an individual case. Obviously, that's not a systemic solution. One more systemic solution might be compassionate release policies. So these are policies that allow people to be released if they are terminally ill or just very medically unwell. Those policies exist, but very few people actually succeed in being released by them. Some of that is because of policies that restrict who can be eligible for them, often based on the nature of their crime and what their sentence is. There's also outside forces that inhibit that. Places, often nursing homes, etc., won't necessarily take people who are being discharged from prison. And some people have been incarcerated for so long that they no longer have family or social ties on the outside to help them. And there's also a whole bunch of probably interesting questions related to healthcare coverage and ACA flux that would be interesting to explore. And then lastly, in conclusion, I would say, the big picture solution would be social change. So this is a group called the Release Aging People in Prison, RAP. They are New York based and headed and started by a formerly incarcerated man. And they are older people many of them who are formerly incarcerated, who are working to advocate for the release of older prisoners. So I would say this is definitely a more systemic change, although we would also want to think about people who still get left inside. So this is part of a broader movement against and to push back against mass incarceration. And I would also say, just because I know I'm out of time, that we are seeing some good things happen in terms of sentencing reform, shorter sentences. We are seeing people get released earlier, but often the people who are stuck aging and dying inside are people who have very long sentences and people who have violent convictions. So I think in this pushback against mass incarceration, we need to really think hard and not leave out people who are convicted of violent crimes. Often they are kind of just left and not dealt with, and we just say, oh, we'll release all the nonviolent drug offenders, and everything will be okay, and that's actually really not the case. So we need to actually really think about what it means to